So Matt and I, we split our education session today. I will start and I will talk a bit about LCH in children and presentation and treatment, just as an introduction, because I didn't manage to submit my bio in time before the program was printed. I'm a pediatric oncologist in Vienna and also doing some basic science, but now I will just talk about the clinics. This is very basic, but just to quickly remind you, LCH, the interesting thing is you have these tumorous lesions that consist of these cells and lots of immune infiltrates, and you can have that in different organs, these accumulations. And the interesting thing a bit is that it's fairly similar no matter in which organ you find it. And for practical reason, it's divided in single system and multi-system disease. Single system meaning that you just have one organ affected at one or multiple sites. A multi-system is more than two organs involved. And the important thing is the risk organ involvement or not? And that's liver, spleen, and hematopoietic system. The interesting thing here is that it's not really defined by any tumors we find there, but it's often, at least in part, a functional definition, especially for the hematopoietic system. The clinical manifestations are diverse, of course, and this was why years ago we were thinking these were very different diseases. 150 years ago there was this Handschüler Christian, Vetterer Siebe, and eosinophilic granuloma, just because it's a very different disease extent, but then it turned out it's actually one disease. One interesting fact is that there seems to be some age dependency on the clinic. So the sickest children are the really small ones, and risk organ involvement is usually seen in children under 2 years of age, whereas multifocal in children between 2 and 5 years, and after the age of 5, it's mostly single bone lesions. So that's now, that's now oversimplified, but in general, this is the case. And we don't know why this is. And I think if we understood this, we would probably understand the disease better. In the next 4 slides, I'll just show you some of the clinical presentations. This is the typical bone lesion in the skull, where you can see these punched out lesions. Here you can see one of the vertebrae, which is really almost gone. This is a skin lesion, quite a extensive one. It can also present as a soft tissue lesion. This is really difficult. You need to biopsy this because this could be also rhabdomyosarcoma, for example. And these are 2 other presentations of skin LCH. So you can really easily mix it up with many other diseases. And usually, I think from clinical practice, we have the experience that people come after they have had this skin rash for a couple of months. Here you can see the lung lesions and how extensively the lungs are destroyed. They can recover very well after treatment. So how do you treat? I think most of you have been at the disease session. We know there is the LCH4 study, which I will talk a bit about. And then there, of course, the elephant in the room, the MAP kinase pathway inhibitors. Where do we place them? In general, prognosis for single system disease is excellent. Survival is more or less 100%. Multi-system disease, survival is between 80 and 90%, but there's specific subgroups which fare not so good. And the huge topic are the relapses. Clinical trials run by the Histocyte Society started in the 90s. We now have the LCH4 study, and the LCH4 study is based on the results of the first 3 studies. And this is just showing you how much prognosis got better with chemotherapy. This is the survival in risk organ positive patients, and this is the LCH3 study, and you can see that the survival is much, much better. And whereas the reactivations after no active disease in risk positive patients also became much, much better. So this was based on a more intensive chemotherapy treatment, which was effective in most patients. Here, I summarized some challenges we have. So one is the mortality. It's between 20 and 20% in risk organ. LCH, and here depends whether, important factors, whether they respond to the first-line chemotherapy. Another thing is the disease reactivation. Almost 50% are refractory to initial therapy or develop relapses. Of course, morbidity and hospitalization are a huge issue with the LCH4, and the question is, for some patients, can we actually reduce treatment? Permanent consequences, I think that's one of the major issues. We have different problems, orthopedic abnormalities, hearing loss, and diabetes insipidus, which usually is not curable once it's there. And of course, the neurodegenerative certain LCH, where we have really no idea how to treat it at the moment, I'd say. Here I just added some of the goals of LCH4. So one is decrease mortality, reduce reactivations, investigate certain STCs, and then study the natural cause in patients which have a single site lesion which don't really need systematic treatment. It's currently open in 24 countries, and so far it has almost included 2,000 patients. And I hope in the next couple of years we will be able to close this study. Here you can see the study protocol. Usually you start with the stratum 1 for these patients who need treatment, but there's also one stratum where you just have the patients who don't need any treatment. This is the stratum 6. And then depending on how they respond to chemotherapy, and I'm not going into detail here because either you treat them, the patients you know, or you forget it anyway, but you try to make some clinically adapted treatment. And there has been lots of discussion this morning, of course, about these two strata, because stratum 3 is the salvage therapy is extremely toxic, has a very, very high morbidity, and you think, why would you treat a patient with this if we have the MAP kinase inhibitors? And the same is for the stem cell transplantation. So there hasn't been a single patient included in this study. Here again are some of the questions of the different strata. I don't think I have to go into this here, but there are a couple of randomizations and some of them are closed already, so that was good. Other chemotherapies, there is in Texas Children with Carl Ellen is the recent trial. So it's a frontline randomized trial with cytarabine. And so this will be, and I think there has been talk about this morning as well, is just to see how does this fare in contrast to the prednisone vinblastine, which we are using in the LCH4 study. So I think this will be interesting. So now for the targeted treatment, as you know, and Matt will talk about the biology, so I think that's the only biology slide I have. It's an ERK-driven disease. You always have a mutation in the MAP kinase signaling pathway, usually in BRAF V600E. MAP2K1 is also fairly common, and then you have some fusions and some other mutations. These mutations make that we have a constitutive activation of the pathway. But I have to say, and this I want to emphasize, we know what's happening in melanoma, for example, if we activate this, but in LCH, we don't know for sure. We don't know what the inhibition does because it's also not quite clear what the MAP kinase passive active activation does. It's probably not like it's in other cells that it's just growth, for example, because you don't see that many mitotic cells in the lesions. So monotherapy with a RAF inhibitor inmalignancy. In other diseases, in oncology nowadays, people think you're a bit mad if you do this because I think this has been quite an important paper. More than 10 years ago, this is a patient with multiple metastases of melanoma who was treated with vemurafenib. And you can see after week 15, he's almost in remission. I mean, this is amazing, I think. But then you can see that a few weeks later, the disease recurred. And of course, no one in melanoma is using a RAF inhibitor as a monotherapy. You always have a combination with another drug. Nevertheless, it was started in children, and I'm mostly showing children data here. So the first paper, I think, was from the French in JAMA Oncology of an infant who got vemurafenib and fairly quickly got in clinical remission, as you can see here, with the albumin, which is quite a good marker in some kids who have a very severe disease. So this case report showed that it's actually efficient. And then a few years later, there was a patient from Slovakia who was also treated with vemurafenib. And I think this patient is interesting because you can see the very, very fast kinetics you can have with this inhibitor. Perhaps if you just look at the thrombocyte, so that's the green one, is that the patient fairly quickly has normal thrombocyte values after start of treatment with the inhibitor. Then here was the inhibitor was paused. You can see immediately the thrombocytes fall. Then the inhibitor was started again and it goes up again. And this is also reflected by the other values. So we see a very, very fast response in some of these very sick patients. This is the only adult data I show. It's Eli Diamond Nature paper, and they showed that across all histocytic neoplasms, MEK inhibitors are extremely efficient. Just look at this progression rate. So the disease stability is, I think, amazing for these entities in the adults. Jean Donadieu then collected and published in 1919 a paper, a retrospective analysis of vemurafenib in children with multisystem Langerhans-acidosis. I think these were around 70 patients. And again, he could show the very high efficiency. So these are patients who are risk organ positive. Here we have patients who are risk organ negative. And this is day 1, and this is week 8. And you can see that most patients respond quickly. So after 8 weeks, the disease activity score is much, much lower. Survival is almost 100%, but you can see withdrawal. If you stop the inhibitor, most patients relapse, so that's a huge problem. And the colleagues from the US published something similar. Again, they showed that the response rate is very high. They have here a bit of a lower response rate, but it's because they have a different outcome. So in the JCO paper, Sean used the disease activity score, whereas here it was, I think, RECIST criteria. What they also pointed out were this persistent presence of mutated BRAF in peripheral blood. And the peripheral blood BRAF you can probably take as a marker for disease extent. This is a paper published by the French who showed the disease activity score and how this correlates with the amount of BRAF in the peripheral blood. And you can see that the more mutated alleles you find in peripheral blood, the higher is the chance that you have a more extensive disease. So you can say at diagnosis, if you have a lot of BRAF, you probably have a more severe disease. What happens if you give chemotherapy? And I think this is urine, but nevertheless, you give, this is before treatment and this is after treatment. Same here, you can see that in most of these patients, after chemotherapy, you have a drop in the allele frequency of the mutation. So showing chemotherapy somehow removes the BRAF allele. With vemurafenib, this is not the case. This is again the JCO paper, but in the Eckstein paper, there are similar plots. You can see that there is nothing. You give this for a year, and the vemurafenib does not manage to remove the disease from the blood, even though the patients are often in clinical remission. So I think that's an important take-home message. You can see these very quick kinetics in this one patient, which I like, because again, you can see how very well there is no correlation between peripheral blood, so that's peripheral blood BRAF, and these are the BRAF levels in the blood, and you can see this is a diagnosis. We could measure it in the patient, and then it goes under the therapy with the vemurafenib. even though this patient went in clinical remission. So this is the disease activity score. So the patient was super sick, then he got the inhibitor, immediately he got much better, but the BRAF levels would go higher, higher, higher. So I think the question is, what happens? What happens to the cells? What are the cells doing? It's technically difficult at the moment to really find this out. But we did some single cell sequencing of the bone marrow of this patient and then looked which signaling pathways are activated. And we didn't find any evidence of cell death, for example, but we found that in these bone marrow cells, many of the cells actually switch off an inflammatory signaling pathways. So leading us to postulate that the RAF inhibition perhaps just inhibits systemic inflammation, but it cannot remove the cells. So I think for any clinical study we might do in the future, we have to be careful using BRAF as a biomarker. We can use it as a measure for disease burden at the time of diagnosis. In patients with chemotherapy, the DNA levels seem to correlate with disease extent, but not if we give a RAF inhibitor. And we have to be really careful in also in comparing data, because techniques to measure this are quite heterogeneous. So in any prospective trial, we really need to evaluate mutated BRAF. So I'm here pointing out two trials that are actually going. For both of them, I think Carl is the PI. So one is the CUG trial with the Day 101 drug. We have heard about this in the morning. And I think recruitment is going to start. Or have you started? Okay, this will be interesting. And there's the Nacho Cobimetinib trial, which we also heard about in the morning. And again, there are 4 different patient groups which can be included. And here, MEK inhibitor is studied as a single agent, but there's an amendment in planning with a combination. Also be interesting what comes out here. So Carl and I also have been invited to this Accelerate meeting, which I thought was really extremely interesting. It was about MAP kinase pathway inhibition in low-grade glioma and LCH. And we then summarized this, and I think there's a paper coming out soon. But for LCH, there's these 4 things which were pointed out. One is to eliminate the risk of death, improve treatment efficacy, reduce morbidity, and prevent or effectively treat neurodegenerative LCH. And of course, everyone pointed out that in the LCH field, I mean, everybody is using these inhibitors, but there's no real trial except for the 2 trials in the States at the moment. And there really is a need for systematic development. And I hope that after the few days here in Stockholm, we have maybe a bit more of a plan what we're going to do. Definitely, and I think that's the problem, biology needs more work because we need to understand it so that we can design a trial. We need preclinical studies and preclinical models. I don't think we have, I mean, let's say we could have better preclinical models at the moment to design also combinations. But of course, at the same time, nobody wants to go back to an area before the RAF inhibitors because it's working. So I think if we want to design a trial now, and acknowledge that we don't know a lot, we can still draw from experience that we have from a large amount of retrospective data. So these are my favorite biology questions, I think, which we should know or at least try to answer. And that is, what does BRAF-ERG activation really do in LCH? Which cells are important? We know you can find the mutation in many different cells. Are there differences between driver mutations? Can you generalize? Like, would you use Ertam-Chester similar to LCH with the same treatment combinations, for example? And what is neurodegenerative LCH and how can we prevent this? For the study design, the relevant questions: which classes of agents within class and combinations? There are many different RAF inhibitors around. which are the best. And one important thing is, we've heard also today, is how well do they get into the brain, how long to treat, which are the target populations. Also here, opinions differ quite a lot. Molecular risk stratification with the MRD measurements, and are there late effects of the prolonged use of these agents? What happens if you give a MAP kinase inhibitor to a small child? What happens to the child when it's 15-year-old? And I think that's my last slide. At the Accelerate meeting, there was also patient advocates, and they pointed out these three things, which I think we should bear in mind. They were really concerned about the potential adverse developmental impact of the MAP kinase pathway inhibitors. And we should really get together with industry to define also functional outcomes. So the disease endpoints or the study endpoints for any new design would be important. And we have to plan good trials, because any commitment to evaluating one therapy in a small patient population eliminates other potentially more promising opportunities. So thank you. I want to point out the Vienna team, of course, with Milan, but also the collaboration with the Europeans, and yeah, just introduce the people in my lab. Thank you.
Any questions?
I think it was so clear.
Yeah.
I think, Matt, it's your turn.
It was very clear. Great. I'm going to follow up with some more discussion of pathogenesis, and also mention a little bit at the end about LCH in adults. Okay, so I'd like to divide the pathogenesis into two sections. Specific questions. So this relates to the point Carolina just mentioned at the end, is how does MAP kinase activation lead to the differentiation of LCH cells? And I completely agree with, there's many things we don't understand about that. And also another point that she alluded to, which is the fact that the mutations are persistent in the blood of patients who are treated with inhibitors, and what that might mean. So we're quite lucky in LCH that there's a really good pathological phenotype. So CD1A and Langerin, and even if you've got BRAF mutation, you can look with this VE1 antibody. And this is a touch prep. And these are the famous Birbeck granules. So you wouldn't do this clinically, but this is the thing that led investigators to unify LCH with the Langerhans cell. So this phenotype, if you see it in the wrong place, and in the right pathological context, so outside of the epidermis and outside of the T-cell areas of the lymph node, this is a very obvious clue to the pathologist that you have Langerhans cell histocytosis. And we're much more fortunate than our colleagues working on non-Langerhans cell histocytosis, which is still a useful term now, I think, because the molecular pathology has kind of unified these disorders. But the real difficulty here for the pathologist is there are many beautiful macrophage stains, but they remain just macrophage stains. And these, you can get this kind of appearance of a inflammatory macrophage infiltrate in many other conditions. So it's much easier to call LCH under the microscope than it is to call non-LCH conditions. And as we just heard, there's a nice sequence of mutations beginning with the MCSF receptor, which is obviously important in macrophage and dendritic cell differentiation, and these other members of the signaling pathway that activate some abnormal property in these cells that leads to LCH lesions. And from a hematology perspective, maybe an adult hematology perspective, it's very nice to compare this with myeloproliferative neoplasms, which have a similar sequence of mutations in the thrombopoietin receptor and the signaling molecules in this pathway that cause polycythemia and essential thrombocythemia. So this is one way to think about this if you're talking to your hematology oncology colleagues. This is the monocyte dendritic cell myeloproliferative disorder. It was the branch of MPN that was missing until these mutations allowed us to see where it fits in. So let's get into this question of how a cell with a mutation becomes a Langerhans cell in a lesion. So there's a couple of ways of thinking about this. One way is to imagine that a dot shows where there's a mutation, that the cells carrying mutation don't actually look any different until they get quite close to the lesion, where suddenly the aberrant function appears and the cell turns into an LCH cell. And if you have that model in mind, it does make sense to talk about a cell of origin, because there may be cells that look completely normal, they carry a mutation, so for example a monocyte or a myeloid dendritic cell, and then something happens in the periphery where this mutation leads to an abnormal phenotype. So you can kind of legitimately talk about a cell of origin. There is another model that we should bear in mind though, which is more akin to the development of leukemia, where you're familiar with the concept that you can have leukemic stem cells that don't look anything like normal hematopoietic stem cells because they've got mutations. And the difference here is that the mutation straight away leads to a different trajectory of development. So in this sense, it's a bit harder to say there's a cell of origin, because every step in this development, the cells are different. It makes more sense maybe to talk about a trajectory of neoplastic differentiation. And I think it's fair to say we don't know which of these models is more accurate. Maybe there's a blend of them in different risk groups in LCH. And you might even use LSC to denote LCH stem cell here. But one thing you can graft onto both of these models is that this deviation from normal development is probably enhanced by inflammation. And in turn, the lesion is dependent on ongoing inflammation. So if you interrupt this, and that can be something as simple as a biopsy or a course of steroids, and you remove this impetus, then normal development can resume. So the expression of the mutation is intimately linked to the inflammatory milieu. So there is some evidence, I think, that this might be occurring, and I'm looking at data from Miriam and also Carl, looking at mouse models and also human progenitor compartments, where if you look comparing healthy and people with LCH, there's a difference in gene expression between these two states, suggesting that these are separate. The catch with this is that LCH is a mixture of mutated and unmutated cells, so you can't really distinguish between those. But in the mouse model, you can separate mutated and unmutated cells. And there's a number of studies in the peripheral blood. There's a nice paper from Carl looking at DQ expression. There's a study that Caroline's just mentioned, looking at differences in the peripheral blood compartment in patients with LCH. And there's this recent study, I think it just came out yesterday, from a South American group, where they show that there's potentially even a little bit of Langerhans expression. It's very low in the peripheral blood. So most groups don't see a high level of Langerhans expression, but it's possible that this taking of the blood and analyzing this leads to this very subtle expression of or shift in the Langerhans axis. So some evidence that there is a deviation in the trajectory of the cells carrying mutations. So I just want to delve into that a little bit more, because we know that several cells in the blood can potentially express Langerhans. And in fact, what it turns out is that the expression of Langerhans in 1A is not such a pathological event. It's not even restricted to Langerhans cells in normal healthy tissues. And this is an experiment we did a few years ago, where we just took different fractions of myeloid cells, and you'll see this is Langerhans up this axis. If you just hold the blood in the tube overnight, you get a little bit of Langerhans expression, mostly on these CD1C positive dendritic cells, less so on the monocytes and the plasmacytoid DCs. And you can augment this expression with TGF-beta, which is a a well-known growth factor that induces languorine expression. So this is a kind of program that can be adopted by healthy myeloid dendritic cells without too much stimulus. They do this quite naturally. And I think there's data emerging that this languorine CD1A module is expressed across a range of myeloid DC. And I'm just showing you data here that Egla Kveddereit is presenting in a paper. I think she's presenting it on Monday. And the data here is derived from this integrated multi-omics data set with different dendritic cell populations. And you can see this expression of CD1A and languorine is shared across a number of different dendritic cell subsets. So it's not only, it's obviously highest in Langerhans cells, but it's a module that can be induced in other lineages, and particularly induced in the context of inflammation. And I think there's data showing that it's also a signature that's induced in association with tumors. So if we delve into this in a little bit more detail, I've mentioned plasmacytoid DCs and monocytes. These are easily spotted. These are the blue guys, and everyone knows what a monocyte is. But there's a bit more complexity in this myeloid dendritic cell compartment, where there's obviously a lot of interest in relation to Langerhans cells and LCH, because these are the cells that are most close in phenotype. So you may be aware that myeloid dendritic cells have these myeloid markers, 11C, 13, and 33, just like other myeloid cells, including granulocytes and monocytes. And then within this population, there's a so-called CDC1, which is a minor population. CLEC9A is a good marker, also XCR1 is a good marker of this. And CD141 is that BDCA1 marker you might hear about. And then this other larger population, originally known as CDC2 for conventional or classical dendritic cell 2 with CD1C. So these are the guys that I was just showing you express languorine quite easily. Now, it turns out there's a little bit more complexity in this subset, and there's actually two components that you can split by. One that is more sort of like a classical dendritic cell. It has this antigen BTLA, and this one it's been a bit difficult to tease out because it shares monocyte antigens, but it's very distinct from a monocyte. It comes down this DC pathway. So the current classification is we have something like this: DC1, DC2, and DC3. And I promise it's not going to get any more complicated than that for those of you who aren't really into splitting dendritic cells, because this is now kind of based on single cell transcriptomics, and it seems to be where the final description is going to lie. So we were interested to see which of these subsets like to express languorine and under what conditions. And you'll see that if you take a monocyte and you just give it cytokines, you get this tiny bit of languorine expression. But you can give a notch signal. So this is a cell-to-cell contact signal mediated by a number of ligands known as JAG1 and 2, or delta-like ligand 1 and 4. And that allows the monocyte to express a high level of languorine. So that cell there starts to look quite like a Langerhans cell coming from a monocyte. And then when you look at these new categories of DCs 2 and 3, the DC2, just like the CD1C that was originally described, will make this languorine expression just with cytokines. The DC3, the one that's a bit more monocyte-like, is a bit more monocyte-like in this behavior as well. It needs a notch signal as well. So we were curious to ask the question how these different lineages that potentially could all form LCH cells, how they would interact. And you can see here that when you do these different conditions, you get nice Burbeck granules in all of them. So they're kind of bona fide LCH-like cells. And what it emerges is that they have different requirements, as I've just said. So this cell will express languorine quite easily. These two guys need a notch signal in order to express languorine. And it turns out also, sorry, let me just go back to this one, that this cell will spontaneously express some of the notch ligands that are required for this cell to express languorine. And I just wanted to mention that this phenomenon was first described in the lesion by Caroline's group, a very kind of important observation that you have, this is one of the Notch ligands, and this is the expression of Notch, that if you look within the LCH lesion, there's plenty of signaling going on between these LCH cells. And I guess the question we were asking is, is there a sequence or a difference between these different lineages? Because this one already expresses the Notch ligand. So potentially, if this one has spontaneously acquired the phenotype, it then might induce the Langerhans LCH phenotype in these other two cells. And the full story, you can hear it from Egler in Scientific Session 1. But essentially, this does seem to be the case, that this cell that readily assumes an LCH phenotype can then trigger the same phenotype in these other two cells. Okay, and this would summarize the finding on this kind of diagram. So potentially we have two separate lineages, or three if you count monocytes as well, because we can't distinguish between these two when we get to the lesion. And potentially this DC2 is inducing a Notch ligand that then causes this phenotype to converge in the lesion. And when you do single cell in the lesion, you can see the kind of remnants of these differentiation pathways by these two different routes. So another sort of twist to the tale, that there are multiple lineages, maybe potentially not one cell of origin, but several routes to making an LCH cell. And as Caroline showed several years ago, the role of Notch in driving this is probably quite important. So I'm going to finish with that little section, and then I'd just like to present a few newish bits of data on this question of why the mutation persists in the peripheral blood of patients. So you've just seen one of these kind of figures. So this shows the level of BRAF mutation in different risk groups of LCH, and you'll see that patients who have single system LCH, mostly you can't detect mutated alleles in the blood or the cell-free DNA. But if you have multi-system LCH, there's a few patients that are positive, most are negative. And then most patients with high-risk LCH, multi-system risk organ positive, have easily detectable mutation in the blood. And I think this is Carl's paper back in 2014. Also lots of data from the French group. Shanghai, Beijing group also have similar data here. And this is UK patients recruited to an LCH4 biology study showing the same kind of phenomenon. So everyone is able to demonstrate this at diagnosis, that the level of DNA correlates with the risk group of the patients. And as we've already heard, this is potentially going to be a useful biomarker. You may even be able to stratify high and low within high risk. So we did actually dot one little T in this, dot an I, cross the T, which is to look at other mutations, because all that work was done with BRAF, V600E, which is the kind of easiest one to have PCR reagents with. So we raided Carl's freezer and got a bunch of patients who had other mutations, some MAP kinase mutations, an ERBB3 mutation, and showed what seems to be the same pattern, that regardless of the mutation you have, you're more likely to have circulating mutated alleles in multi-system risk organ positive than risk organ negative, and more than single system. So potentially this BRAF accounts for sort of 60% of childhood LCH, but potentially this kind of analysis can be expanded to a larger group of patients. So as Caroline also showed just now, when you look at the disease activity and the level of mutations in the peripheral blood on patients being treated with chemo and going into remission, you'll see that they get better. The disease activity score falls down, and the BRAF mutation, whether you look at the plasma or the peripheral blood, also becomes undetectable. And as far as we know from correlates with the clinical studies over the years, these patients are effectively cured. They might still be at risk of late effects and neurodegeneration, but they don't have any violent systemic reactivations. And in contrast, when you look at patients who are treated on inhibitors, and I should say that all of these have failed chemotherapy already, so they're a slightly different risk group. They have low levels of disease activity, and you can see the odd attempt to reduce the inhibitor results in a sudden spike in disease activity, as has already been described. But you can still detect plenty of mutation. This is, sorry, the scale's dropped off here. This is years. So this is peripheral blood mononuclear cells, and cell-free DNA measured over years just remains positive. And the children are blissfully unaware of this, but the doctors are doing probably most of the worrying because they can see this mutation, and pediatric oncologists don't like to see mutations in their children from a very valid experience with leukemia. I think I showed this slide a few years ago where I confidently said, well, it's not leukemia, because say if you had a Philadelphia chromosome in the bone marrow in a patient with chronic myeloid leukemia, this Philadelphia chromosome has a selective advantage on the stem cell compartment. The stem cells with that chromosome gradually expand and take over. The patient becomes overtly myeloproliferative because the mutation confers this growth advantage in the progenitor compartment. And then, of course, if you give an inhibitor, because you're inhibiting this selective advantage, gradually the clone will shrink away and the person will get cytogenetic and then a molecular remission. And then the difference here again is you can then stop the inhibitor and the patient remains well. In contrast, in LCH, and I think lots of data would support this clone stays quite small at a few percent, never more than 10%, I would say. And from that, if you see that over several years, you maybe propose that this doesn't confer a selective advantage on the progenitor cells. They don't massively expand. They don't overtake the bone marrow. And the data from Miriam and Carl looking at the effect on senescence would support this, that actually cells in the proliferative phase with this mutation might even have a disadvantage against wild-type cells. But anyway, the corollary that's important is if you then apply this inhibitor to this low level of mutation, because it's not expanding, it's then likewise not going to contract when you take away that selective pressure. So I thought this would explain the whole story, that the mutation persists because there was no survival advantage, and when you apply the inhibitor, it's more acting on the peripheral lesions, maybe breaking that inflammatory cycle in the tissues, rather than affecting the output of mutated cells from the bone marrow compartment. But there's a twist in this tale also, because when we broke down this mutation into different compartments of blood cells, so it's a bit busy this, but if you just look at this, say, left-hand panel, so this is the proportion of mutation in different fractions of blood cells, and basically red and orange are the monocytes and blue is the myeloid DCs. You can see that the DC mutation burden is dropping to undetectable. But curiously, the black is T cells, and the T cells over, this is now 6 years, are gradually acquiring these mutations. So if you look at this mutation burden 6 years out on the patient, it's not actually in the myeloid cells anymore, it's in the T cells. And this is the mutation burden per microliter of blood, so similar data, just a different denominator. And the pie charts showed us the proportion of mutations present among the different lineages. So red and orange is monocyte and black is T cell, and you can see in these 4 patients that the mutation effectively switches from the myeloid compartment to the T cell compartment. So we were a bit surprised about that. I'd initially done the T cells as a control, and then we went back and read the literature more carefully and found that Caroline had already shown this in a few patients here, particularly this one who I think had a transplant, where again the mutation was exclusively in the T cell compartment, and in these other 2 patients there was a decent chunk of mutation in the T cells. So we wanted really to see if this was a really generalizable phenomenon. So with the help of Carl and Ashish, who raided their collections, we got all these are individual samples, not necessarily individual patients. But if you look over 5 years, you'll see that this mutation burden switches almost exclusively to the T cell compartment over this 4 or 5 year period. And the other catch with this appears not to relate to inhibitor treatment, but just the duration of time, because some of these late patients only had a few months of inhibitor. They already had a lot of mutation in the T cells. So what might this mean? Well, this is very conjectural now, but the well-known thing that happens late in LCH patients is neurodegeneration, and you'll see this nice study from the Paris group that the rate of neurodegeneration slowly rising after 5 years and plateauing at sort of 10, 15 years. And that's a sort of similar kinetic for what we're seeing in this peripheral blood compartment. And indeed, some of the patients in the study had been on inhibitor, and then this one patient had actually stopped their inhibitor and, with low-dose methotrexate and hadn't reactivated in the systemic, systemically, but they had started to develop neurodegeneration. So I just wonder, I raise this really more as a question rather than an answer to anything, but whether the mutation in T cells could be playing a part in neurodegeneration, particularly because T cells do have access to the CNS. We know this from diseases like multiple sclerosis, where they play quite a significant pathogenic role. And it may not be the whole story. You may need both. You may need a high burden of mutated myeloid cells early in the disease, and then something weird about this. But we should definitely try and look at the biology of these cells, I think. Okay, so more questions than answers, but hopefully will stimulate us to go away and have a think about these things. So just in the last part, I want to give a brief survey of LCH in adults, which is not so well studied as in children, and most of the protocols we use, we borrow heavily from pediatric practice. But one of the things that I just want to highlight, and this is data that's just about to be published from England, so not the UK, it's England now. So NHS England finally got its act together to collect all the digital data relating to pathology codes. And the nice thing, again, relating to that first point, that LCH has a distinct pathological phenotype, there is a good path code for LCH. So you can go in your cancer registry in your country and find who had LCH and link that to outcome data as well. And I guess the two take-home messages are that this is adults, or adults are curiously defined as over the age of 14 in these digital data records. But basically, there are as many new diagnoses over the age of 14 as there are under the age of 14. This little slice here is the other neonates under the age of 1. So you can see the incidence per million is 10 times higher in the neonates, and these are the ones getting risk organ positive multi-system LCH. But there's this very long tail. Some of these age groups are quite large. But LCH continues to be diagnosed in younger and older adults. The overall incidence is about 1.5 per million. So finally, some good incidence data in adults. And this is my sort of cartoon of what LCH looks like in children. So I still think these broad older descriptions are kind of useful. The risk organ positive multisystem disease is the same thing as Litera-Seaway. And Hanschler-Christian, otherwise known as chronic relapsing LCH, you still see this pattern of disease, neurodegeneration we've heard about, and of course the odd patient just gets an eosinophilic granuloma, maybe presenting as a vertebraplanar or a single flat bone lesion, and then there's pulmonary LCH. So a lightning tour there, wasn't meant to go into detail, but the spectrum is kind of different in adults. And when I was writing this slide, I kept coming up with D. So there's quite a lot of DI in adults. Dentition is a major issue. Many of them are short of breath, even if they've stopped smoking. They have, either good radiographic LCH or LCH in the lungs that overlaps with chronic bronchitis and just general respiratory dysfunction. Some of these obviously progress to end-stage fibrosis and require lung transplant. And then things to do with the neurological system are also a major problem, and sometimes it's very frustrating because the scan looks completely normal. We're probably not all doing the volumetric scans that Eli Diamond has shown as useful in Chester patients, so maybe there is some actual brain shrinkage, but certainly the MRI can look very normal. But they're often depressed with mood disorders. They're often dysarthric. People think they're drunk some of the times, and I invented this word dystaxia to keep it all Ds, but they quite often fall, they drop things, they lose their jobs because they're clumsy. One of my patients used to be a forklift truck driver, and he soon found out he couldn't do his job. And then this one, there's a huge amount of pain. There's a huge amount of skeletal pain, whether it's post-inflammatory pain or something specific to LCH. It's quite hard to elucidate. And, you know, you end up doing repeated PET scans that are negative, but still the patient has pain and very refractory to any treatment. All classes of analgesics fail. They go to pain services. Sometimes the best intervention is to have a really full-on psychological and psychiatric input, allowing them to develop coping strategies for this pain that really starts to dominate their lives. And there's a fair bit of dermatologic, which isn't always LCH actually. Quite often you do a rebiopsy and it's nodular prurigo or something like that. But when you apply LCH treatment like methotrexate or 6-MP, the skin seems to improve. So this can be a little bit murky as well. They seem to have poor skin, and only some of it seems to be pathological LCH. Now, of course, this amazing document is produced by Gaurav Goyal, and I recommend everyone to read it because it does really summarize the state of the literature and the state of the expert opinion, which we rely on a lot in adult LCH. But he also highlights this kind of different features that you see in adults, and this prominence of DI, prominence of respiratory problems, and he does comment on the difficulty of treating chronic pain. But it's a really useful document, and we should also acknowledge Michael is the senior author on here because he produced a previous guidance on this, which is now 10 years old, but it's really stood the test of time and was also the kind of go-to document before this one. So this is the real kind of striking feature that came from this NHS England data that I found really shocking actually, and this is how bad the survival of adult patients is. So this is your little neonatal death blip here, this tiny little loss of survival in multi-system risk organ positive LCH neonates. Otherwise, the children do relatively well, and also the younger adults. But as soon as you get over the age of 30, 40, 60, your survival is really poor. And this analysis wasn't able to dig into the health records to find out what the cause of death was. I think that would be the next step. We suspect it's not always LCH related, but it's really, almost a priority to try and find out what's happening to these not so old and older adults. And I thought I would just show a case briefly at this point to illustrate the kind of things that can happen to these patients. So I had a guy about the age of 25 was diagnosed with lung fibrosis, and he was advised to stop smoking. So he stopped smoking and he was stable. He was employed there, but it's always been a bit of a loner. His parents lived nearby, but anyway, he managed. And then about 10, 15 years after that, he suddenly started getting headaches. He had blackouts as well. He was falling a lot. He had a full admission to hospital and evaluation, and was found to have these punched out holes in his skull. He had several. This is a bone scan. Also a few little hot spots elsewhere. One of these was biopsied. It was a nice eosinophilic granuloma, and LCH was diagnosed. It's BRAF wild type at this point. And then everything kind of, the picture dawned that this was probably pulmonary LCH along with this bone involvement. Anyway, he was given cytarabine because it was fairly active multi-system disease. we didn't like to give vinblastine and pred in this age group. And he did have some improvement. His pain went away for a while. He was more mobile. But other problems came along as well. He got celiac disease diagnosed. He had several biopsies, and I'm pretty sure there wasn't any LCH in his gut, but he had problems with maintaining his weight, and vitamin D and also iron levels were low. So another problem that came along. And then for 10 years, he just got worse and worse skull pains. He was falling a lot. He used to get injured. He'd come in with this sort of huge black eye where he tripped over. He got recurrent chest infections. He had repeated imaging over this 10 years, and the PET scan was never hot again. The MRI brain was always reported as normal, even though he had, quite a noticeable cerebellar syndrome. And he had this chronic pain. His memory was terrible as well. And he lost his job. He became socially isolated. And at the age of 51, 1 January, he was just found dead at home by his relatives. He had an autopsy which showed pneumonia on a background of chronic bronchitis. It was put down, and the pathologist didn't even put LCH on the death certificate, even though his medical record was full of this LCH. They were like, well, that's kind of a rare thing that occurs in children, isn't it? Did he have it as a child? Was it really relevant? And actually, probably the only thing I did for this guy was get LCH put on his death certificate, which is almost part of the battle. But his relatives specifically wanted it, as the cause of death. That he wasn't just, he wasn't just neglecting himself. He had lots of reasons that his health was impaired by this disease, I think. So I think that probably explains some of that terrible mortality in the older adults, this kind of case. Okay, we have a range of treatments. Most of these are borrowed from the pediatric world. Just to highlight a couple of things, bisphosphonates seem to be useful. The patients almost become a bit dependent on this. There's a really interesting study from Dr. Makras in Greece showing that denosumab, the rank ligand blocker, can be useful in the skeletal pain. I tried it once and it didn't work, but I should probably try it again. We use a lot of non-steroidals. We use a lot of maintenance therapy. Ken McLean also suggested the use of hydroxycarbamide, which can be useful even to control pain, even when there's no blood count abnormality. And of course, we have MAP kinase inhibitors to salvage some of our patients. It's particularly useful with the Hanschler-Christian type refractory problems where there's a lot of disease in the skull, and also potentially useful in pulmonary LCH, although we don't really have the data to back that up yet. And then we end up doing a whole lot of this supportive treatment with analgesia. We use Ritalin to try and cope with the fatigue. Some patients find that useful, but mostly psychology and pain services become really important. So I'm sorry, I raised another question here rather than giving you an answer, but this is really puzzling why you have all this terrible skeletal pain. So I was just digging around and looking at this basic science study. This is from Martin Guilliams, who's one of these mouse macrophage experts. And one of the interesting things is you'll be aware that there are macrophages that come from the yolk sac and that live in your body forever and ever. And there are some macrophages that are continually produced from the bone marrow. And it turns out, this graph here shows the percentage of macrophages that come from the bone marrow after you've done a transplant in a mouse. And so this is brain microglia. So the microglia stay for life from the yolk sac. Even if you transplant the bone marrow, you don't change the microglia. And the blood monocytes, if you transplant the bone marrow, they obviously come from the donor. But this is sural nerve macrophage. So a lot of these guys are coming from the bone marrow. So potentially, if you have a disease where there's an abnormal macrophage floating around the place, I don't know if this could be doing something to the nerves. It's wild speculation, but having seen the burden of symptoms, I'm becoming motivated that we should look in this area. I think that's my last slide. Yeah, so just like to thank various people, Paul Milne, who's done most of the lab work, and Venetia, Sarah, Moshkin, also occasionally get dragged into LCH work in the lab. Egler and Florent, who we've collaborated with, and also Carl and Ashish, who provided a very generous load of patients for the mutation switching to T cells, and Jean and Mylène were also. I spelt Mylène seems to have become Paul. Also Carlos and these funders, and then a whole bunch of really supportive UK clinicians. Olga was speaking this morning. Trung's in the audience. I'm very pleased to see you. So our new hope in LCH in the UK. And some of you might know Paul. He's not here because he's on paternity leave. He's been doing his own lineage diversification here. So thank you. I'll end there, and happy to take any questions. Maybe Caroline wants to come and... Are there any questions at all? Are you taking your microphone off? So it's gone. Yeah, hi.
Hi. Well, it's a truly Thank you. It's a truly fascinating presentation. I have a couple of questions. The first is about the slide when you showed the prevalence of the mutations in patients as the single system disease versus multi-system with or without the RIS organ involvement. And the panels showed 2014, 2017, 2021, and the most recent data from LCH4. And whereas the pattern is there, in those panels, you see progressively more of the mutation expressors in the single system, LCH patients. If you go back to that slide, you'll see that. So does it reflect actually our ability to detect the mutation?
Oh, I see. Yes, I see what you're saying. You think that over time?
Over time.
Well, that one's low still. This is a bit, we've put everything positive and negative on here, so actually that's the, so where's it? And this is low risk, which includes risk organ negative multi-system. We don't actually have many of these guys, because those clinicians that I acknowledged, they don't send us any blood from the single system patients. I'm not sure that's real. I think Caroline raised a point that we have to standardize this methodology, whether it's allele-specific PCR or ddPCR. I think we both agree they're similar in performance. I know that when Carl first produced this figure, I think some of these, this was all at diagnosis, wasn't it? I think, yeah, okay, yeah. I think my point here was that whoever's looked at it finds the same thing. So hopefully it should be quite easy to standardize the this as a tool. I think what's really interesting is whether this, whether these 10% guys are a separate group to these 1% guys. We were talking this morning about whether there was a kind of super risk organ positive, who you might want to shave off and do a different kind of clinical study. Although of course you obviously reduce the numbers when you start doing that.
Right. Second question was about looking for mutations in the peripheral blood cells. Mm-hmm. So it's not really semantics, but what exactly the cells that we're looking at? Monocytes, lymphocytes, and then what kind of lymphocytes?
Okay, good. Yeah, in this bit. Well, sorry, I didn't show the data because I didn't want to kill everyone with data. But so these.
No, the probably next slide. Or after that, really the peripheral blood cells.
Yeah. Okay. This bit. Okay. So yeah, good question. What are these guys? These. So that's the classical monocyte.
Can we go to the slide before?
The slide before? That one?
No, before.
This one?
This slide. So peripheral blood mutation, which cells are we looking at here?
Okay, these 4 patients, sorry if I didn't explain that, 3, 4, 5, 6, are these guys. It's the same. So then they're split. Yeah? All right. So that's the bottom of the previous slide. I did it deliberately to confuse you. No,
that would be also okay.
So monocytes and myeloid DCs. It's a good question about the T cells. I skipped over it because I was concerned that when you look after 4 years, you might just see a memory T cell, maybe even one clone, 2 clones that happen to have a mutation. They expand to maybe 10% of the T cell population, and they just sit there. They don't do anything. But when we fractionated this by memory and naive, most of the mutation was in naive T cells. And also some start to appear in B cells and NK cells as well. It's spread a bit more. But it looks like it's not just a clone of memory cells. It looks like it's something that's being continually produced from the bone marrow.
So then all this happened at the level of very uncommitted pluripotent stem cells, right?
Yeah, possibly, yeah. So the difficulty then is, so the reviewers will say, go and look in the bone marrow. But the kids are super well at this point, right, and no one is going to do a bone marrow on them. But potentially, if you had that experiment, you might show that the clone is skewed from the bone marrow.
But you wouldn't call it a germline event, right? Because then it would be solved by skin fibroblasts.
Yeah, it's definitely not, for sure, it's not germline. The variant allele frequency is still 1% single figures, so it's a low VAF. I guess the other question is whether, if you leave these patients long enough, 6 years, maybe 10 years, and it's only in the T cells, can you then withdraw the inhibitors? When I ask this question, people say, no, I have a patient for 10 years, I take the vemurafenib off, they still relapse. But I know that certainly our experience, most of the time we tried a treatment withdrawal was in this early phase when it was, the drugs were new. We thought, great, the kid looks amazing, let's just stop the drugs. I'm not sure how many people have tried to withdraw later on. I don't know. Caroline, do you want to comment on that? Yeah.
We tried it later also on the patient who had it almost only in the T cells.
Yeah.
And he did relapse.
Ah, no way.
Yeah, but
okay.
just a tiny bone lesion.
So this guy.
Yes. Mm.
Yeah.
And for the lineage switch, is there maybe a theory as to why this even happens? What's the driving force, especially if the BRAF has no survival benefit?
Yeah, I don't know the answer to that, but I don't think it's related to the inhibitor, because also I didn't show, one of these patients had imatinib for 6 months. Some of these patients were only on inhibitor for less than a year, and they already had high burden in the T cells. I think also if you look in Carl's data from the paper on neurodegeneration, there's quite a bit of mutation in T cells. So I think this phenomenon was maybe happening all the time. We just didn't have the molecular test to look at a sensitive level. So we have to be careful to say it's an inhibitor effect. It may not be. It may be a natural history phenomenon. So which is why I think it's maybe connected to neurodegeneration, because we've always had neurodegeneration. That's not a new thing, yeah.
So that means that if all the patients who would not be treated lived forever, eventually they would have all this, right? T cells, monocytes,
yeah,
expression everywhere.
No, it goes away from the monocytes and it goes into the T cells.
That's what I say. So
yeah.
If this is just a natural history of progression at the molecular level,
yeah.
If you left those patients untreated,
yeah,
then you would eventually see the expression of the BRAF mutation in the T cells.
Yeah, potentially, yeah. I think the other point that people make is that these children used to die before, so maybe we didn't have the inhibitor allowed us to see a phenomenon. But the other thing that's interesting to see, if you look at a JAK inhibitor in JAK2 positive myeloproliferative neoplasm, you also don't see a loss of the mutation burden until you get to like 10 years out in adults. So it's worth looking at the MPN literature to see, do we just need to go for 10 years? I don't know. I'm sorry, yeah.
Thank you.
Daniel.
Yeah, regarding the JAK inhibitors in MPNs, we see that even in the registration studies, half the patients lose their response after 3 years. But could we perhaps use this knowledge that you show us that the T cells are the cells that are preferentially mutated after a long time, to say that if we have a patient who fares well on vemurafenib, could it be the time to say, well, then try to let us do something about the disease. Despina musculosus just showed us that alemtuzumab is quite safe in pediatric HLH. We know from the MS setting that alemtuzumab crossed the blood-brain barrier, and what we're worried about here is, of course, neurodegeneration. Could we target, when these patients are well, they can probably tolerate alemtuzumab anti-CD52 treatment, and could this potentially be something that could be of relevance? Dimitri showed last year a great way to look at tandem approaches to change treatments, but this could be considered.
Yeah, it's a great idea. I love that idea. I mean, yeah, I think it will take some persuading of the adult physicians, maybe because we use the MS is a good example. We should consider that. Maybe we would need more preclinical evidence that the T cells are connected to neurodegeneration, but for that matter, CD52 is expressed on monocytes and DCs and everything. I don't know. I mean, the other thing that would sort of lower risk treatment is 6-MP and methotrexate. Maybe, I don't know if does anyone know if did 6-MP and methotrexate ever prevent neurodegeneration? Maybe not. No.
Thank you, Matthew. I have one question. I mean, when the BRAF story broke, and then the first animal models of expressing BRAF showed leukemic phenotype, and now you put together all this data showing that early event and precursors, possibly even the hematopoietic stem cell, and then it can differentiate along the line. So what I'm wondering is, why don't our patients get hairy cell leukemia?
Yeah, that's a great question. I mean, it's especially relevant in ECD, I guess, where you have the same demographic. You have older male patients who gets ECD and who gets hairy cell. The interesting observation is that there's a lot of clonal hematopoiesis in ECD patients. Maybe hairy cells don't have clonal hematopoiesis, they have a different clonal hematopoiesis. I don't know. It's a great question though, because there's good data showing the hairy cell has the stem cell compartment also has the mutation all the way back. So, great question. I don't know the answer. Is it time? Oh, Olga. Not as a distinct subgroup. So the question was, how is this myeloid to T cell switching in patients with neurodegeneration? All I can say is that a number of the patients around this point were switched onto inhibitor because they had neurodegeneration. Okay. So, that's why I stress that I don't think this is necessarily an inhibitor-driven phenomenon. The inhibitor may just have allowed us to see it in more patients. Okay. Great. It might be time to explore Stockholm. Any more questions? Great. Well, thanks everyone for coming. I hope it was useful. Thanks to Carolina as well. Great. Thank you.